Yeah, her question was that at any time during the treatment have we had to interrupt the treatment either because of side effects from the surgery or side effects from the chemotherapy or even side effects from the radiation. And unfortunately we do have to do that. We try not to, and sometimes we take a stepwise process. We may, if they're doing chemotherapy, we may halt the chemotherapy. If they're doing radiation, we at least try to get in, 2 consecutive treatments back to back. So like even our upcoming holidays, our therapists work very hard, and even though we get days off, they don't. So they're here on those holidays treating patients just so that there aren't any interruptions in their care. But if there is a wound issue, if there is something that needs to, if the patient comes down with pneumonia, heaven forbid, or some other problem, then yes, then we can delay. We try not to interrupt our treatments. If a patient is hospitalized, we try not to interrupt our treatments more than 3 to 5 days. So.
What happens if it is interrupted greater than 5 to 7 days?
Then most patients may have to be resimulated because the marks may have changed or whatever was causing them to be hospitalized. If it was fluid in the lung, if it was an infection, if it was a question that the tumor might be recurring, then we'd have to have a restaging scans or PET. And sometimes, with mesothelioma, if the disease is progressing faster than the treatment, we may have to abort the treatment and go on to either chemotherapy or other options. Her question is, what type of mesothelioma do we not touch? I would say it depends on the performance status of the patient, because even those patients that may come to us already that have a metastasized mesothelioma, that is not going to be able to undergo surgery. It's not going to be not even strong enough to get chemotherapy, but is in pain because these tumors are growing through the chest wall. That's a palliative radiation, but radiation is still effective in killing those cancer cells, and so it would be a shortened course of radiation, 2 or 3 weeks, but to address the symptoms.
This would be more of a palliative.
Yes, palliative. Mm-hmm. And it might not be the only one. So if they, recently we've had patients who, we've had to spot treat. So they may do the 2 weeks of radiation or 3 weeks of radiation to the area that's hurting the worst and allows them to get a better energy level, a better performance status, and go on to get more chemotherapy. And then down the road may have another area that's getting out of control. So then we could treat that area. Yeah, for not dealing with nausea during the radiation is a difficult problem. I mean, we use diet changes, we use everything that we can think of. We use standard compazine, Phenergan, alternatum, Zofran, bigger guns, even steroids, dexamethasone that might be alternated with the other 2. We use Marinol, which is the cannabis drug, along with the others. Again, we try everything as many times, but it's gotten better because many times it was if the radiation's not given, to limit the amount of areas of the diaphragm or below the diaphragm that are being hit, then nausea and vomiting and bowels were worse. So with our growing technology and ability to limit the radiation to those areas, the nausea and vomiting gets better too.
How often do you have to have a feeding tube put in with our mesothelioma patients?
Many times our surgeons, she's asking how many times do we have to have a feeding tube placed for mesothelioma patients. Here at MD Anderson, it's again a multidisciplinary approach. So our surgeons and even our medical oncologists, they think about that at the beginning. They look at those side effect profiles of chemotherapy. They look at when they're going in to do the initial staging workup with an exploratory laparotomy or looking below the diaphragm into the abdomen. They will think ahead and they'll place a feeding tube then, so that way it has time to set in. And many times our patients are tired, so they don't want to sit and eat a full meal. So having the feeding tube in place, is actually welcomed once they get to that point. They think about it and they think, oh, I don't want to go through that. That's the last thing I want to do. But after they have it done, then they're very thankful.
So if you're hitting the diaphragm with radiation, do you have any problems with the cuts?
Yes, and problems with hiccups during radiation is a lot of that is associated with the nausea too, or just the digestion. You know, because they're also on narcotics that slow down the digestion. So then they're bloated, they're nauseated, they're not eating as well. The narcotics are constipating them, and so it all comes to a head together.
What do you normally do for the hiccups to control them?
We'll try the Reglan, you know, for initially for nausea. We'll try changing the diet regimen, and I rely on my dietitian. And or we'll use, you know, Thorazine if we need to, or refer them to our wonderful supportive care. So we have supportive care who deal with a lot of those issues and are specialists in that area. She's asking if we can use proton radiation as this type of radiation that we've talked to and that is most generally used is photon radiation, and it's just the different techniques, three-dimensional versus IMRT, you know, versus other high doses of radiation compared to proton radiation, which is really big at MD Anderson right now, and allows sparing, even greater sparing of the normal tissues. I think that at this point, I don't know of anybody that's using proton radiation, but I see being a research institution, I see a lot of our physicists' minds turning, and they start to talk about, well, you know, if we did this with IMRT and we have proton, then, you know, we need to look into collaborating with those things. That it might be a little bit difficult just in I didn't show you slides for proton, but the radiation, when it's given in general fashion with photon radiation, the beam has to get hotter to its target and then it falls off. So as opposed to proton radiation, the beam gets hotter and then drops off completely. So there's no gradual fall off back here. But because mesothelioma affects the pleura or the lining, I think it's difficult to try to get the hot dose as close to the chest wall. You know, so, but I know that they're thinking about it. They have rapid arc IMRT, and they have all their brains going. They're looking into this.